Stuck doing invoices manually? Get unstuck with SPLOS. Harness powerful features like batch invoicing, automation, and finance integrations to save hours every week. SPLOS. Practice management handled.
Good morning, everyone, and welcome back to our second keynote session today. My name is Derek Munn, and I am the Director of Policy and Public Affairs at the Royal College. It's a pleasure to welcome you, and I'm particularly keen, after some brief housekeeping, to welcome our second keynote speaker of today. Now, I'm not sure if a housekeeping slide is going to appear. I'm aware some of you will now have heard the housekeeping twice and will be getting ready to learn to say it off by heart, but just to remind you of the key points. Questions in the questions tab, please. We won't take questions from the chat tab. The chat tab is there, but please be respectful, and we will be monitoring as we always will, and help is there for technical help as well. So that's it for my initial housekeeping. I'll be back at the end to tell you about the secret code and the feedback points. But now, when we were deciding what we should do at the conference, we had a number of areas in mind. And when we considered inviting expertise around the area of public health, we were all immediately, this is really important. We know this is a topic that's of importance and interest to all of us, but perhaps that we don't have as much understanding about as we would like to have. And so we were delighted that William was willing to be a keynote speaker for us today. So it is my pleasure to hand over to William Roberts, the Chief Executive of the Royal Society for Public Health, to give us his presentation. William, the floor is yours.
Thank you, Derek, and thanks very much for inviting me, everybody. It's really brilliant to be here speaking to you. So hopefully you can see my slides. I'm going to go through this, but if you've got questions, please do, as Derek said, drop them in, and we'll try and get through them all and give you some time for that as well. I'm also, during this, going to ask a couple of things that you may want to just pop into chat so that you can just see some examples of the brilliant stuff I think we're doing as well. So slightly later on, I'm going to ask you to, if you can get thinking about it now, to put into the chat the things that you are doing that you believe are helping you to support both better public health and prevention through your day job. And so it'd be really interesting to see some of those coming through. But I'm going to start a little bit just talking about how do we really tackle inequalities and shape public health. For those of you that don't know my organisation, when I'm trying to find my moving myself on my slide, but that's not working, so I shall stop sharing for a second and have another go at doing this. But if I talk a little bit about kind of why are we doing this, well, the first reason is really to think about some of the challenges of why it's important to think about public health. Well, firstly, we know that health drives growth. So if you want to be a prosperous and healthy nation, you have to have people who are happy, healthy, and able to contribute to your communities. And that can be really simple things like, if you're not well enough to work, you can't go out and earn a living, you can't make any money for yourself, you can't pay your bills. And not only does that mean that you don't personally have the ability to support yourself and keep yourself well, but it also means that you're more likely to require support from the state, both of which have real challenges for you. And so we know that this idea that we want people to be healthy, and the way that we can create that health is by giving them both control and agency and supporting them to stay well. And some of that requires us to do interventions, and some of that requires them to do interventions. And I'll talk a little bit about that in a moment. But secondly, not only, we've done loads over the last 100 years to help people to live longer, but the challenge we're facing now isn't how long we live. And peak human is probably about 95 years life expectancy, and we're kind of getting there now. We're somewhere close to that. We're probably getting, for the average person, that you will live for a fairly long time compared to even 20 or 30 years ago. But the difficulty is not only are you going to be living longer, but you're more likely to be living with long-term ill health. And so, somebody said to me the other day that the challenge is that 60 is the new 40. but actually 80 is still the old 80. And so by the time you get to 60, people are starting to show a range of illnesses and multiple long-term conditions which they'll be living with for life. And that isn't just that, as in the olden days, you got older and you got sicker. We're also starting to see people presenting much earlier with conditions. So, for example, we're now seeing children presenting with type 2 diabetes. So what was, when I first started clinically working, described as old age diabetes, is effectively something we're starting to now see in children due to lifestyle and due to the way in which their body is able to process the food which they take in. And so this challenge of we live longer but not necessarily healthier, and that also creates a difficulty for us, because if the answer was just more healthcare, so giving people more healthcare, we just put more and more money into healthcare. And actually over the last sort of 30 years, we've done that. There's been huge increases in the amount of money we spend per head on healthcare in the UK, but we know that that's probably only responsible for about 10% of all the health you have. So as well as the idea that you can have access to healthcare and services, we also know that the world you live in, the conditions you live in, your home, your work environment, your friends, your family, the lifestyle choices you make, the air you breathe, those are the things that also impact on your health. And if we learned anything from the COVID pandemic, it was that a strong public health response needs more than just treatment in the NHS. It isn't just about waiting for people to get sick and treating them with ill health. And so we do need a healthier nation. So we've got these challenges. These are the challenges that you're facing every day in your jobs, whether you're working in the NHS, whether you're working in the private sector, whether you're working in the voluntary sector. Wherever you're working as a speech and language therapy, you are finding one of these challenges. The first is that people have growing physical and mental ill health. So the challenges of the people in front of us are greater than they were 10 years ago. And, you know, if I go back to when I was working in the NHS, probably 25 years ago now, I would see people coming into my my wards who were very, very sick. Those are the people I now see living in the community. And so we've seen a shift in acuity over the last 25 years. We also know that it's really, really hard at the moment. You're all working really, really hard. There's long wait lists. We know that people are doing everything they can to make the services work, but it feels stretched at the moment. And that's partly because we're busier than we were before, but it's also partly because there's less services around us supporting us to do the work, as we've seen the challenges of less public sector funding over the last 15 years. I've already talked about premature mortality and stored life expectancy. So people live longer but less healthily, but also we still know some people die disproportionately earlier than they should do. So if you have learning disabilities, you're 50 times more likely to die by the age of 50 than a general member of the population. And that is almost entirely from modifiable health conditions. So that's not from things that can't be managed, that is from things that you could do something about. We know that financial pressures and economic inactivity are a huge issue at the moment. We know there are people who can't work, and particularly thinking about some of the people you'll deal with, the challenge and support that they need in order to be able to do certain jobs, to have the confidence to do it, to recover after the condition that has affected them. Those are things that are really important to getting that person back into the working environment. And then finally, we also know that just because you put in more services, just because you do a really good job of identifying the challenges, we still see the problem that those who need our care and support the most are the least likely to get it. And that might be about geography and where you live. You know, if you live in a coastal or rural community, it can be very hard to access services. It might be about your ethnicity. So we know certain groups are less likely to get access to services and have less trust in those services. Or it might be just that you can't afford to go out of the house to get to your appointment. And so there's a whole range of reasons why it's really difficult at the moment. So why am I talking to you today? I mean, I'm not a speech and language therapist. It's an amazing job. It's a brilliant career to have, but I'm not one of them. And why should you listen to me? Well, firstly, because I think you are a fascinating group of people. I think, firstly, because the opportunity for you is the access to support. Nearly everything you do is preventative and long term rather than short term. There are a few things you can do which will be about the person in front of you here and now and the immediate issues they face, but nearly everything you do is about preventing long-term problems and about supporting people to live better and live healthier and live happier over a long period of time. And that's really interesting because very few professions have that. Most professions will have some things they do which are immediate, some things they do which are medium term, and some things they will do which are long term. But for yourselves, you are almost entirely delivering preventative support over a long period of time that will, from potentially from the day somebody is born to the day they die, the things you do to them will impact on them and have something that will promote their better health over their life cycle. Whether that's early on in their life through children, whether it's people in middle age, or whether it's people who later in life are struggling as a result of their health conditions, you have a unique position. Secondly, we know that the people coming to us are coming with a greater level of complexity. Now, that might be that their lives are complex, the things that are going on outside of their health are complicated. That could be about people trying to do 2 or 3 jobs. It could be about people who don't have access to funding. It could be about people who aren't able to access education and support in the way they need to. Or it could be because actually they're not just coming into you with one problem. So you may have to deal with the one issue, which is, to do with their speech and their language, but actually it could be a whole range of other issues that are underlying that also need addressing. We also know that early intervention can transform lives. And, I'm sure from anybody who's been in the previous sessions today or is going to be, I looked at the programme for the next 2 days. Some of the sessions are genuinely brilliant. Genuinely exciting sessions talking to people about how things you can do can transform lives. And then I think the final thing that's really interesting about speech and language therapy is, as therapists, you have access to people that may otherwise not present to other services, because they'll come to you with a very specific need, which is very much obvious, but may not present in any other way to any other service. And so that idea of how do I look at the person in front of me and see the whole person and the opportunity I have, and I might be the only person they engage with in the health and care system. That's really, really interesting, but it's also a unique position you have. And I think in generally, amongst the allied health professionals, that is an opportunity, but I think particularly for yourselves, that is going to be a way in which people present, because quite often the issues they have are impacting on their day-to-day life and therefore need intervention. Whereas for some of the other professional groups and for some of the other issues people may come to you, they may be able to live for a very long time with those issues without needing to have support or it becoming obvious to anybody else. And so that's a really unique thing only you can do. We're going to talk a little bit about what we've done as an organisation around workforce and around preventative skills. So back in 2024, we launched a report called The Unusual Suspects. Effectively, what we wanted to do was to look at people who didn't have public health in their job title. So people who weren't necessarily seeing themselves as public health professionals, and work how could we do something for them. And we found 3 things that they said consistently, irrespective of which professional group they were in. First, they wanted to do more. They wanted to do more that was preventative and to offer clear entry points into the public health system. Secondly, once you got in, it was incredibly hard to get on. So you might identify that you wanted to do public health, you might identify a way in which you could access that, but then there wasn't a clear way in which you could then build that into your career, build that into your professional development, and build it into your ongoing job. And then finally, even if you got in, even if you then got on, you still didn't necessarily get people recognizing that you were somebody who could deliver these things, whether that was through your organization you worked for, your line management support, or whether it was other professionals who were working in that space. And, I said that we talk to a lot of people. In the membership of RSPH, we have about 6,500, 7,000 members across the world. Of that, we have well over 200 professions in our membership. And that is everything as diverse as toxicologists to tattooists. People who see themselves as having an opportunity to improve the health of the person in front of them. And we know that allied health professionals and speech and language therapists are a big part of that membership. And so this isn't just about where you work. It isn't just about people working in the NHS. It isn't just about people with the word public health in their job title. It is amongst a whole range of different people. And it may be a time now, if you've got some time, you've had some thinking, it may be worth thinking based on what you've heard so far, and do pop this into the chat, Are there things that you've done in your job that you want to share with others that makes you a public health professional and part of this wider public health workforce? And it would be great for others on the call to see the kind of things you've been doing so they can get a sense of, if that was me, could I also do some of those things? So please feel free to do that, and do that for each other rather than for me. It's not a test. So engage with it if you want to, and if you don't want to, feel free to do that. But certainly, if you think you want to share with somebody the brilliant stuff you've been doing in public health, do that now, because actually we heard time and time again from these people, I do all this brilliant stuff and it doesn't get recognized. But also, once I explained it to other people, they suddenly went, I could do that as well. So just have a moment to do that whilst you're listening to me. One of the things I wanted to talk to you about as well was that when we talk to people and we ask different professional groups to contribute to our work around workforce and the wider public health workforce, we also wanted to show that they don't just work in the NHS. And so when we looked at who was responding to our questions, we could actually start to see lots of different types of workplace appearing. And it wasn't just necessarily people working in the public sector. We saw people from the private sector, the voluntary and charity sector, local government, higher education, schools, national government, and all the international aid agencies all applying and saying, I am a public health professional and I want to be heard. So if you're not working in the NHS, or you're not working in a public health team and you're a speech and language therapist, that doesn't stop you from doing preventative work and being brilliant in that space. So one of the things that they were telling us they were doing, well, 65% of them said, well, actually, when I make decisions, I'm trying to understand how this might impact both that individual and the community they live in. So thinking really clearly about the impact on public health when making those decisions. Many of them were talking about going out into communities and directly working with people and engaging members of their community in preventative work. People were talking about promoting healthy living, so the opportunity of making every contact count, that I've got somebody here and I might be talking to them about their swallow reflex, but I might then also talk to them about healthier foods they could eat, which would also support them to be able to swallow safely. Or it could be that actually in the process of talking to somebody, it becomes apparent that a child hasn't been vaccinated. How can you think about supporting that parent to ensure that they know how to access a vaccination and they understand the benefits of that for them and their child? Similarly, we know nearly 50% of people were engaging in conversations about mental health. Somebody would present to them with a physical health issue, and as they spoke to them, as they assessed them, they realised that that person had mental health problems. And some of those people were doing interventions for them around mental health. Some were just signposting them onto further services. But actually, the idea was they were doing a different range of things for these people. And then we also saw all sorts of different bits in there. And again, all the way across here about health and safety issues, promoting and protecting public health, advising people about specific issues they were facing, correct hygiene standards. So, people were trying to understand whether that was how to use a bit of equipment or how to keep their house clean and tidy, how to protect themselves from infections. People were having those conversations with them. So just to talk a little bit about what we do in this space. So we're about 180 years old. We're the world's oldest public health body. Amongst other things, we are also an educational charity. So every year we provide training and education for over 40,000 people. And that's everything effectively from level 1, which is sort of very entry level GCSE, all up to level 5, which is effectively sort of pre-degree diploma level. What was interesting was we'd never tried to join up that offer in a way that made it accessible to the workforce to build their skills and build their career over a lifetime. And so over the last 2 years, we've been developing a range of products which meet the needs of different teams and different organizations, packages of training. So to think about, whilst I'm doing some training on public health, I might also want to do something on behaviour change. I might want to do something on vaccine hesitancy. I might want to do something on mental health. And so packaging together training opportunities for people. And we're doing that, interestingly, with everybody from social care staff to allied health professionals to people working in football clubs. It's a really diverse group of people that we're training and developing skills in public health in. And at the heart of that is effectively giving people a GCSE in public health. And it's not a GCSE, it's a level 2 qualification, but to sort of put it in context for everybody else, it's equivalent to a GCSE in public health. And then finally, we've also been developing career pathways. So as you develop in careers and organisations where you don't have a clear career pathway, we've been working to support people to do that. And that's across a range of sectors. So what do I think you can do? So the first thing is I think you can see something in prevention, that this is something we can do and something that makes a difference. It's about creating a mindset that says, I've got to do something here which is long-term and preventative, rather than just something that is patching up the problem and sending the person back out into the world. The second is to think particularly about how do you make every contact count. As a very simple example, if you work in an accident emergency and you have somebody who has a traumatic injury that was related to alcohol, 1 in 3 people will significantly change the amount of alcohol they consume to safe levels if somebody says to them, do you think perhaps that you drank too much alcohol? If you talk to 1 in 4 people when they have a respiratory condition who is a smoker, they will seek to quit as a result of that. You can really make massive differences. We know that the opportunity to talk to men about their mental health, for example, is hugely powerful, with just a few words of support for that individual around embracing the fact that they may be suffering with mental ill health. The third thing, I think, is to think about, what do you as speech and language therapists, what are you particularly well placed to do? And I think that's a few things. I think it's, firstly, you're there to really prevent longer term public health problems. I said earlier, not many people have that opportunity, but you really do. And I think that starts with the fact that you have an opportunity to do that in children, young people, and vulnerable groups. And those are the groups you're working with, right? Nearly everybody who comes into you is vulnerable in some way, because they do not have the ability to necessarily articulate their needs in a way that they would want to. So you are working with people that you can make a massive difference for. I think there's a lot of stuff you can do about working multidisciplinary teams, and we know over the next couple of years, neighbourhood health and multidisciplinary teams will become more of the norm, particularly for those working outside of hospitals. And then also, I think it's about, how can you train and expand the skills of other professionals in understanding communication needs? That actually, how can you really help build awareness of the things you do in others? So when you're working with nurses, when you're working with doctors, when you're working with paramedics, when you're working with play therapists, what is it you can do to support them to understand some of the skills you have? So I'm going to stop there, because that sort of rattled through in about 37 minutes. All the different things that we've been doing, why I think you are an amazing public health workforce, but also I thought I'd like to give you a bit of time for a few questions.
William, thank you very much indeed. That was absolutely fascinating. And when you do get to look at the chat, you'll see in amongst the technical messages, a lot of really interesting ideas from people about things they're doing and could do. Thank you for leaving so much time for us to reflect. Fascinating set of questions have already come in. Some of them, I think, are questions for us as speech and language therapists, as opposed to ones that you might know. But let's have a wee go. And the one that's been liked the most is about saying, just from your perspective in public health and prevention and tackling inequality, would you have anything to say about well-being and the mental health of health professionals themselves, sustainable practice in the pressures that people face today?
Yeah, I mean, it's a really good question, and it's a question I think that is being faced by lots of different sectors. So I think the first thing to say is if you want to have a healthy population, you also have to have a healthy workforce that is supporting that population. Sometimes the organisations that are responsible for doing that are not the best organisations in the world at doing that. I don't think it's particularly contentious. I did 20 odd years in the NHS before I left for working in the voluntary sector and some time in the private sector. Whether or not I think you got great support was down to your line manager. It wasn't down to a corporate approach. And so there's something for leaders to think about how do we support the people that are working for us? How do we create an environment that promotes their health? And I think that is 2 levels to that. And I think we do need to separate them out. There are some very clear physical things we can do to support that. That's about, making sure, for example, everybody's had their flu jab coming into winter. You're going to be working with vulnerable people. The flu jab protects them and it protects you. And that's a really simple example, but we need to make time for people to be able to do that. We need to make that as simple as possible. In my organisation, everybody is offered the opportunity to have a flu jab for free. We support you to take time off during the working hours to do that. and we also help to explain to you the benefits of that, but also give you the choice to take that up or not, and we give multiple points at which you do that. The reason I give that as an example is because lots of organisations will say we offer the flu jab, but you've then got to make it possible and feasible for that person to do it. If that person's working Monday to Friday, 10-hour days, and the only place that you can get that is from one outlet, that's going to be really hard to do, especially if you don't give them the time off. We take the view in my organisation that giving people the time during their working day to go and do that is hugely advantageous for us, because it takes 10 minutes to do, and we only have to have one person not being off for one day, and we make back that time, as an example. And that's a very simplistic example. There are other things you can do around paying your staff a decent wage, supporting people with flexible working, ensuring that your policies support people to be able to be supported physically with their health, ensuring there are good food options available if you provide food within an area, transportation, active travel, those kind of things. So there's lots of things you can do physically. I think mental health is a different issue that we need to be honest about, and because there's two sides to that. The first side to that is all the things I've just described in the physical health, about ensuring the support's there, so people have support, they have the opportunity through better line management to be supported around their mental health. But I also think it's about the culture in which you work, which means we know it's high pressure. It's very high pressure working in a charity. You know, money's tight everywhere. It's very difficult. We've got growing demand, growing wait lists, etc. So how do we ensure that those individuals feel safe? There's not a culture of bullying. People aren't feeling pressured to deliver, and if they are, they're able to talk about it and support it to deliver. And how do we make the systems as simple as possible to support people to work in a way that supports their mental health? And I think it is worth saying that, because that's incumbent on leaders, whether that's line managers, heads of department, deputy directors or chief executives, to create those conditions in organisations. It starts at the top with the policies you create and the operating environment you create, and then it cascades down through good line management, and that is really important. So, you know, I do think it's important that we support people to be healthy and happy, but also there's just very simple things you can do, and we don't do them. The other thing about wellbeing, I guess, just as a last piece, is wellbeing is about giving people coping strategies and resilience tools. And I know you've got Dr. Rada coming tomorrow at the end of the day to talk about some of that. Her work's really interesting, where she talks about mindset frames and opportunities to support people in different ways. And so some of this is also about building the resilience tools in our staff, because we know it's going to be difficult. And I could give thousands of examples, but I think it starts with leadership, it then cascades down to managers, and the last person that you almost have to put that responsibility on for physical and mental health is the individual. They need to be creating environments that support that individual to stay safe, rather than expecting that individual to be able to be the one that manages it.
Thank you, Owen. That's really helpful. The next one I'm going to read out as submitted, but feel free to talk around the issues that it raises, if you know what I mean. And it says, how can speech and language therapists lead preventative strategies in schools and communities to reduce long-term health and social inequalities caused by communication difficulties? So I think obviously we've got a lot of people operating in a school setting or a community setting, and how might one lead in those contexts?
So if I step back and say what works for anything in that space, forgetting just speech and language therapists, what's our experience of what works? The first thing is it's about being really clear about what it is that you are seeking to do that is preventative, and how you think that is going to change the outcome. And I say that because quite often prevention can be quite an abstract concept for people who aren't skilled in it or don't have experience in working. It can be anything to everybody. Everything's prevention. In the same way that people will say everything is public health, or that could be public health. And so we need to be really clear about, if you want to develop a preventative strategy in schools for speech and language therapists to lead, what is it you're seeking to prevent? And what are the things that you know work that you will do to make that happen? Because it's a much easier sale to people. Interestingly, if you talk to the public about public health and public health as a concept, they find that quite abstract. They have mixed views on it. If you say to somebody, do you agree that people should be supported to stop smoking? Do you agree that people should be supported to be able to make choices? They'll overwhelmingly support it. As an example, if you say, do you think there should be public health interventions around energy drinks for children? People will say, yes, but I'm not sure what it should be. If you say, do you agree that energy drinks should be banned for under 16s due to health concerns, a specific intervention with evidence behind it, 92% of the population, and irrespective of any political beliefs or beliefs on state intervention versus libertarianism, 92% of people agree with that. It is overwhelmingly supported because it's a very specific intervention. People can understand it and they understand why you would want to do it. So I think firstly, it'd be really specific about your prevention opportunity. The second is change happens at the speed of trust. So this is about building relationships and going out and having time to talk to people. So you can't walk in on day one and say, I've got this idea, I can sort this out, can we do this? You've got to go in first and listen to people. And like I used to describe when I was working in this, that there's two types of strategists, right? There's foxes and there's hares. Foxes have great sense of smell, focused eyes, ears on the front because they're going after a prize to win. Hares have big ears and big eyes because they take in lots of information. When you're going into working partnership, you need to be a hare, not a fox. So don't walk in saying, this is the answer, this is what I'm going to do. Go in, be curious, ask questions, listen. And then the third bit you've got to do if you want it to be successful is work out how you can solve other people's problems as well as yours. Because actually for you, the problem might be one thing, but the problem for somebody else is entirely different. And I can give you a really good example of that, which is I ran a large-scale program in the NHS around supporting care homes to prevent hospital admission. If you said to a care home, walked in and said, I want to prevent hospital admission, that wasn't a problem for them. And it wasn't a problem for them because they needed that support. They sent somebody to hospital because they wanted help for somebody. The problem for them was they had no access to services and NHS support in the home. It might also be that they lacked the training around specific issues and didn't feel confident to manage issues within the care home. When you said to them, what are the problems you're facing? They'd say things like, I don't know what to do when somebody's dying. I haven't been trained to be supported to do that. I can't access the GP when I need it. And if I do access the GP doesn't always trust what I say. And so the solution to stopping people going into hospital was to pull people together and have those conversations about how do we support GPs to come and work with you? How do we get GPs and care homes to trust each other so that they won't waste each other's time? How do we build capability and capacity around end-of-life care in those people? And lo and behold, when you did those things that were problems for the care home, you saw massive drops in the amount of hospitalisation as a result of it. Because that's why they were sending people to hospital. The NHS's problem was people from care homes going into hospital. The care home's problem was not getting the support to keep them in the care home in the first place. And so I think that thing of go in and understand what it is that the school is trying to deal with and has as a need, and how can your issue and your support help to meet that need as well as the needs you see in your system.
Thank you. A huge number of questions, and I'm picking out ones which I think will be of widest relevance. Yeah. The next one I wanted to pick out, it was raised in the context of justice, and you'll know that speech and language therapists have an underappreciated role in the justice system. But it raises a question which I certainly face as an influencer and advocate, which is about combining budgets and getting people to work together, and saying, okay, to achieve these public health objectives, we've got education and health and housing and justice, and they're all siloed. And what's your experience and advice on how we bring these things together?
Very simply, you need three sets of people if you're going to work together. Forget the money in the first place, make the money the last conversation you have. The three people you need is you need bridges, so people can bridge between those organisations and those different systems. Brokers, people can actually broker conversations and can say, this is what we all collectively need. And then finally, you need translators, because the language you use in those different sectors is different and people were having different conversations. And so you need somebody who can actually translate for people so you all understand you're saying the same thing. So find your bridges, find your brokers, find your translators, and then finally when it comes to money, then talk about money, because you'll have started to understand the things that you need to do together and why the money will enable that.
Thank you. Thank you for that. And I should have said after the previous one, I'm going away to work on my inner hair and being more hair and less fox in certain contexts. So that's my takeaway. Thank you. Got a couple of questions which are really about scope of practice. And it's interesting, William, because I've seen inspirational speech and language therapists in fields from adult learning disability to community children's services exactly doing this kind of wider preventative work. But we've got some questions about saying, look, are we not going beyond our clinical remit? Is there a possibility that we're going out of practice, out of scope, if we start talking about vaccination and alcohol consumption and so
on? So personally, I think no, but I caveat that answer. And the caveats are, firstly, you need your organisation to give you the support to do those things. You can go out and do those things on your own, but you need your manager to say it's okay for you to do this. You need an authorising environment that supports you. The second thing you need is you need skills to do it. You can't just wander in and suddenly start talking to people. So you do need to think about what is the training and development you need. And that might be pre-registration training that you build into all people's training as they come through. It might be post-registration training, and it might be building people with specific skills in specific jobs. It's not beyond your scope of practice to look at the person in front of you and take them as a whole. That doesn't mean you have to do an intervention for that person. What it might be is that you understand they need signposting to something else, or they need referral on to a further person, or that they may benefit from multidisciplinary working. And so it's about being able to support those people. And different people working in speech and language therapy will have different levels of that scope depending on what they do, where they work, and the services around them. And so I think it's about having conversations with your line managers and your employer about what is it we see as being the remit for us within that. And again, that's going to be different in the private sector from within the NHS. So I think it's about building that out. And then finally, you've seen inspirational people. We have to showcase and talk about those more. One of the reasons why I ask people to put stuff into chat is because I know there's brilliant people on here who are doing this already. And you may read one of those and go, okay, that's interesting. I'm going back tomorrow and having a conversation internally about, is that something we could also feasibly do? And for some people, that's going to be going a few inches beyond where they are now. And for others, that's about going quite a long way further than they are now. All of which is entirely within the scope of your practice and your professional capability.
Cool. Thank you so much. And your idea, William, putting ideas in the chat has really taken off. And I think the list of ideas and thoughts in there is amazing. And people are asking whether those can be kept and collated.
Yeah,
to which the
I can't
is,
see those, so I would
okay.
love to have those sent through, because they're the sort of things I absolutely love. But please, I mean, there's so many brilliant people on here. You don't need to listen to me to be inspired. You've got to talk to those people that are doing it in speech and language therapy. And
the answer to the question, can they be kept and collated, is I don't know, but I will ask. The next one, with just over 5 minutes to go, is I don't expect you to know the answer, the specific answer for us, but I wonder if you have advice for us from elsewhere. The question is, how are social determinants of health currently considered within speech and language therapy priority rating scales, and what impact does this have on equitable access to services? So I don't expect you to know about speech and language therapy prioritization scales, but do you have any advice for us on how that's done best?
Yeah. I mean, so we know the social determinants of health. They're not new. They first came out 1960s, further reiterated in 1980s through Dargan and Whitehead. This isn't new stuff, so we know what they are. I think the question therefore becomes, when you look at that in relation to your job, when you look at that in relation to your organizational objectives, and when you look at that in relation to your professional standards, where is it you feel you have an opportunity to make a difference and intervene? And a really simple example of that might be that you just identify an issue, and that person that then understands the issue that they may have to go off and solve, or they may need to go somewhere else to solve, but you identify the issue, right? And that's the first step in any of the social determinants stuff. There are then other opportunities to think about that. So, it is quite feasible. I sit on the board of a housing association as an example. We deal with a huge number of older people, particularly through an older people's provider rather than a younger people's provider. We know there are huge issues amongst that population, particularly those with either dementia or post-stroke around their needs. How could we think about designing our services to support them in their home? We provide some care as well. What would the role be, for example, for us? And that it's not necessarily always up to the speech and language therapies to do that. It might be up to organisations that you go and talk to think about that. It might be about, that last bullet point I had on my thing, which is take your skills and take them to the outside world. I think we tend to think about what can I do rather than what can I enable other people to do. But that's a really good example of where, in that population, we probably have 10% of our people living in our homes who will have some level of need from, relatively minor to quite significant. So how do we ensure that we build those skills into our staff, but also we know how to engage most effectively with speech and language therapists if required? You're on mute, Derek.
William, rookie error, thank you. On a couple of minutes left, and I think that the last thing I'm going to invite you to comment on is, again, a challenge to us as well as to you, which is a question around amplifying at a national level the voice we have about what speech and language therapy does. And you talked about in the context of policy in England, the 3 shifts, and there's a role for us as the Royal College of Speech and Language Therapists in clearly articulating the speech and language therapy role in the shift to community, the shift to prevention, the shift to digital, and the economic impact. But do you have any final words of advice for us on how we work with you and work as our own profession in amplifying that role at a national level?
So at a national level, very clearly, organisations like yours and mine, we have to be better at communicating that as one voice. It's why we did the Unusual Suspects report. That's why we didn't call it a public health report. It's why it was called the Unusual Suspects, because it was about championing really hard, and we're really pushing this in the 10-year plan workforce plan that's being developed at the moment. We're pushing this in the knowledge and skills framework redevelopment, which is being done through the Department of Health and Social Care. This is, you've got to factor in this wider group of people rather than just people with public health in their job title. So, that's our job. Your job is to then say, what exactly can speech and language therapists do to that? And partly some of that stuff in the chat is that, and partly some of that is your advocacy work. The 2 things I would add to that is, at a regional level, there is much you can do. You will have regional leads, you will have regional AHP leads. How do you really play into that space and be part of those discussions? There is strength in speech and language therapists as a group. There's also huge strength, I think, in the 14 AHPs coming together, which they do really, really well to speak as one, where there are issues around visibility and ensuring that those skills are correctly used in systems. And then finally, at a local level, stop waiting for something from the centre. In reality, it takes years for national programmes to trickle down to a local level. People just get on with it in that time. So the question is what can you do, whether you're a manager or a person working in a multidisciplinary team, to do some of the things we've talked about on this to just make some of that change happen? Because what's fascinating about all those case studies and best examples, they all did it without any national guidance. And then lo and behold, everybody wants to copy them. But actually, you can go and be your own national exemplar. You can be the next person that everybody wants to copy, but you've got to go off and do it, right? Don't wait for somebody at the centre to tell you exactly how to do it.
Brilliant. Thank you so much. 90 seconds to run through the housekeeping. The recordings will be available for 6 months, I'm pleased to say. Please leave feedback. Not least because of the points, which I'm sure you're all excitedly collecting. Ditto the secret code, which will shortly appear. The annual general meeting of the Royal College is at 12:45 today. All full RCSLT members, please do attend and hear about the work of the organisation and what's been done with your membership fees in the last year. We now have 45 minutes for lunch. There will be drop-in sessions, so please drop into those, and also visit the sponsors, exhibitors, and posters. And finally, on behalf of everyone present today, could I give one more vote of thanks to Chief Executive of the Royal Society for Public Health, William. Thank you so much for your time.